Hello, everybody. My name is David. On behalf of Johnson & Johnson, welcome to today's webinar, Managing OSD to Optimize Post-Surgical Event. Today, we are very thrilled and privileged to have Dr. Preeya Gupta from Duke Eye Center in North Carolina joining us here today and giving us a fantastic webinar. Before we get started, I would like to ask if you could please select one of the following from the screen in front of you. And while you do that, let me take a second and please orient you to the webinar platform that you see in front of you. You'll see that there is a Q&A box at the bottom left-hand. Please feel free to type in questions at any point. Questions will be answered at the end, and questions will be anonymous. There's also a test button question. And for those of you who are looking to achieve CME credit points, please complete the test at your leisure. There's also a survey button at the bottom of your screen. And please feel free to complete the survey towards the end of the webinar. And finally, at the very top, if you would like to have a Johnson & Johnson rep contact you after this webinar, please select the click here, and somebody will gladly be in touch with you shortly. Now, please allow me to introduce our speaker, Dr. Preeya Gupta. She is the Clinical Medical Director of Duke Eye Center and Associate Professor of Ophthalmology at Duke University Eye Center. She serves as an elected member of ASCRS Cornea Clinical Committee and is also the president of Vanguard Ophthalmology Society. And she is also an elected member of AAO, the American Academy of Ophthalmology. Dr. Gupta has lectured at many ophthalmology forums here in the Asia region, and we are very excited to have her here with us today. Welcome, Dr. Gupta.
Thank you so much, David. And thank you all for joining today. I hope everyone is staying safe and well. Today, we're going to talk about managing ocular surface disease in the pre-surgical patient. And this is, a very important topic, whether you're managing these patients preoperatively, whether you're a surgeon, or if you're seeing these patients postoperatively. So I thought we'd start by looking at the actual definition of dry eye disease. The TFOS-DUES-2 released an update in 2017, and dry eye is defined as a multifactorial disease of the ocular surface, and it's characterized by loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, inflammation and damage, and neurosensory abnormalities play an etiological role. So that's kind of a mouthful, but I think that, if you look at the words that I've highlighted here in yellowish orange, those really are the critical words that help us to establish some of those key endpoints when we assess for dry eye disease, but also understand what's happening at the level of the ocular surface. So if we look and say, well, what risk factors are out there for dry eye disease? I think most of us know very well the typical ones, such as women are more common, older age. So as we get older, we're more likely to have dry eye. MGD is most definitely a risk factor for dry eye disease. And we know the vast majority of patients that are coming in with dry eye complaints also suffer from MGD. But I think it's also important for us to focus on iatrogenic causes of dry eye disease, whether it's the medications we prescribe orally, topically. Medications like glaucoma medications are a significant disease burden on the ocular surface, but surgery is a major category. Millions of cataract surgeries are performed annually. And when we look at why surgery can actually create an issue, it's because there's a transient neurotrophic effect from the actual surgery itself, and that can take someone from being asymptomatic to symptomatic. So patients can decompensate after the procedure. So it is really important to recognize that role. And so, when we think about our own patient population, I do a lot of cataract surgery, and a very common theme is that patients come in with lots of these risk factors that we just mentioned. And when we look in the literature, many studies do support that there's a temporary worsening, but sometimes permanent worsening of dry eye disease symptoms. But that, as we look in our own clinics, this, I think, our own clinics mirror what's happening or what's been reported in the literature. But very little until recently had actually been reported about patients preoperatively. And so I want to take you through kind of what are the potential impacts of ocular surface disease that's noted preoperatively, that's not treated, and sort of the consequence of that. So if we look at the PROOF study, this study really confirms that patients will suffer from poor visual acuity or visual quality after cataract surgery. And this really shows that even though we do our vision test and we ask our patients to read a line on the chart, a lot of them are 20/20, but they describe it as, a very poor 20/20. In the PROOF study, 56% of the dry eye disease arm complained of moderate or worse blurry vision, despite having 20/20 vision on a chart, compared to only 14% of control. So patients perceive a negative vision quality. Patients who have untreated preoperative dry eye are also more apt to have a refractive surprise. A study by Alice Epitropoulos and her colleagues showed that patients who suffered from hyperosmolarity, as tested with a point-of-care test, that those patients that were hyperosmolar, i.e. indicative of dry eye disease, actually had much more variability in their keratometry readings, which leads to IOL errors. And then, of course, one that we're very familiar with as clinicians, which is that patients often just don't feel good. They complain of foreign body sensation, irritation, and so we certainly don't, don't want our patients to have a negative association of the surgery with their vision. This is just to illustrate that a number of patients, especially in the premium channel, so patients getting multifocal lenses, or in our refractive population, LASIK patients, dry eye is a major contributor to dissatisfaction as it relates to vision quality. And patients really do blame the surgery when they have these postoperative symptoms of discomfort, visual fluctuation, and poor vision quality. So it behooves us to treat it and to really take it seriously preoperatively. And I really, I put this slide in here because I really think it's so important for us to understand what it means to have a stable tear film. We talked about the TFOS-DUES-2 definition, and central to that is homeostasis of the components of the tear film, but also tear film stability. And visual disturbance is very common when the tear film is not stable. Your patients are not going to come in and say, hey, I have an unstable tear film. They're just going to say, I can't see, or I feel like I can't see. And really, this is because a degraded tear film causes continual fluctuations in image quality, and it can cause 1 to 2 lines of lost best corrected visual acuity within blinks. So if you could imagine, something's in focus and then moments later it's out of focus, blink, blink, it comes back into focus. And so that's a real frustration to patients. And also, really gives a lot of emphasis to the importance of a stable tear film. So let's look in the literature a little bit about what we know as it relates to ocular surface disease at the time of cataract surgery. So this is a study by Bill Trattler and colleagues, and they found that in their study, almost 63% of patients had reduced tear breakup time of less than 5. 77% had corneal staining at presentation. Another study that specifically looked at MGD found MGD to be present in 52% of patients presenting for cataract surgery. And over half of the patients actually had some level of meibomian gland atrophy. So these are both very common at the time of surgery. Dr. Chris Starr and I did a study recently. It was published in 2018 in JCRS. And what we found, we wanted to ask the question, what happens when we use modern testing? So we took 120 patients that were coming to our clinic for cataract surgery evaluation, and we found that 80% of them had at least one abnormal test. So specifically, we used the MMP9 test, the osmolarity test, and then also our clinical exam looking for corneal staining. And so, if you take this, 80% of the patients that we are seeing for cataract surgery have ocular surface disease. That's really, the vast majority of them. And when we use tests like point of care tests, I think it does help us to identify some of those patients who don't have the typical complaints. In our study, over half of the patients had an abnormal osmolarity and MMP9, but not all those patients were symptomatic. So just something to keep in mind, that we can't only rely upon patient complaints of dry eye and irritation. We talked a little bit about, potential errors as it relates to ocular surface disease, but one that I really want to emphasize here is management of astigmatism. Topography and biometry are very sensitive to dry eye and ocular surface disease, and can lead to erroneous measurements of the magnitude and axis of astigmatism at the time of cataract surgery. And so, many times have I had the situation where had I not treated the ocular surface disease, I would have chosen the wrong plan to manage astigmatism. And, it doesn't always change in one direction. So it is important to repeat measurements and have established consistency once the ocular surface disease is treated. So we need to recognize MGD and ocular surface disease. And we really need to address this before surgery to get the most optimal outcomes. So as David had mentioned, I'm a member of the ASCRS Cornea Clinical Committee. And as a group and as a committee, we really felt strongly about trying to put together an algorithm, a guideline for our peers to really rely upon to help identify who are the patients that can pass through to surgery and who are the patients that really need to have their ocular surface disease identified and treated before surgery. And so we developed this algorithm. It's the ASCRS preoperative OSD algorithm. It looks a little complicated, but it's actually very easy to follow, and we're going to work through it here in the course of the webinar today. It's readily available in JCRS. It was published in May of 2019. So let's walk through it a little bit. So first, of course, you have your patient come in, they undergo their normal battery of tests. And then from there, in addition to their topography, keratometry, so in my clinic, everybody that comes in for a cataract evaluation standardly will get swept source OCT or optical biometry and topography. And that's just so I can look at the corneal surface, so I can look at the magnitude and axis of astigmatism and kind of base, at a cursory level before I've even seen the patient, what type of technology they might be a candidate for. From there, we recommend that patients undergo an OSD screen. So this consists of assessing symptoms and signs. And so we've developed a questionnaire called the ASCRS Speed 2. And then for signs, we recommend testing either osmolarity or MMP9 tests. Here in the US, they're both readily available clinical tests. This is what the ASCRS Speed 2 questionnaire looks like. So I'm sure many of you are familiar with the Speed questionnaire. It's a very brief and easy to administer questionnaire. And what we did was we added questions for non-dry eye disease subtypes of ocular surface disease. So to assess for things like contact lens related issues, allergies, MGD, et cetera. And then we also added, adapted from the Dell questionnaire, questions that help the surgeon identify patient goals and expectations. So their desire for spectacle independence, personality questions that help you decide if they're a good candidate for multifocal lens or trifocal lens, for example. And then the signs and symptoms. So it's worth talking a little bit about osmolarity and MMP9 testing. So of course, not everyone has access to it, and that's okay if you don't have access to it. But if you do, understanding why both of the tests were selected is important. They've both been validated in the literature. But osmolarity is really primarily an assessment for dry eye disease. It has a very high specificity. MMP9 is a non-specific inflammatory marker. It's been validated to be sensitive and specific for dry eye, but also can help to identify other subtypes of ocular surface disease. I want to take a second and, I get asked a lot, well, what happens with the normal osmolarity? Well, I don't think a normal osmolarity is helpful. And I really think that osmolarity testing as a screening test is helpful. So, and this study really helped me to realize that. So they took 50 patients that had dry eye disease-like symptoms, okay? And all of them had a normal osmolarity, which effectively rules out dry eye. But they looked at these patients and they decided to ask the question, well, what other ocular surface disease do these patients have? Because they clearly have symptoms. And a lot of them suffered from blepharitis, allergic disease, that's almost half of the population, but also very common things such as conjunctival chalasis, anterior basement membrane dystrophy. And so, the normal osmolarity test does have value because it helps to rule out that dry eye is the primary driver. And similarly with MMP9, an elevated MMP9 can be present in patients with non-dry eye disease diagnoses such as pterygium, MGD, recurrent corneal erosion. That's something that we see, and autoimmune disease. That's also an important one. Patients that have, severe autoimmune-related inflammation. So, once you've done those screening tests, I think, so the committee didn't want to feel that folks had to do a million different tests. But I do think that once those tests are done, there's certainly a number of different tests that you can use to help categorize your patients. Of the tests that are listed on this slide, mybography is absolutely my favorite test because it really helps me to look at what's happening at the level of the meibomian glands and to look for atrophy of the glands. And we'll talk a little bit more about mybography later. From there, the clinical exam is really important. And, of course, we're all, when we're ready to do cataract surgery, we're diving right to our slit lamp exam to see what the cataract looks like. But before you do that, we recommend a targeted or focused ocular surface exam. And we came up with the mnemonic LLPP, look, lift, push, pull. And so look refers to looking at how the patient blinks. A lot of times patients that suffer from MGD and dry eye will only partially blink their eyes. Looking at the interpalpebral, lifting the eyelid. Lots of ocular surface disease hides in the superior eyelid, whether it's Salzmann's nodules, SLK, and then we suggest pulling on the lids. You can assess for floppy eyelids, which is very common, as well as lid laxity. As patients get older, they can have ectropion over time. And then push refers to pushing gently on the meibomian glands to express a little bit of the oil so that you can look at the consistency of the oil to see if the patient has MGD, to see what their vision quality is likely to be if there's deficient oil flowing. And then from there, if the patient has any abnormality, so abnormal symptoms, abnormal signs, or an abnormal clinical exam, so for example, revealing corneal staining, then the patient is deemed to have visually significant ocular surface disease. Surgery should not proceed, and the patient should have aggressive treatment to minimize the delay to surgery. For any other patient that is asymptomatic, that has no signs on their clinical exam, normal point of care testing, then I think that, those are the patients that perhaps, so you've identified that there's something there. Maybe they have mild symptoms, or maybe they had an abnormality that, it doesn't cause decompensation of the cornea. Those patients can be operated on, but I think it's important for you to have a conversation with the patient, that they have likely have some sort of ocular surface disease, and that they may actually have more symptoms after surgery, but that they can proceed because, refractively, there isn't any sort of compromise to the ocular surface prior to surgery. So let's move on and talk a little bit about how are we going to treat these patients. There's so many different treatment options that are out there, but I think the main goal really should be to rehabilitate the surface in the most rapid way possible. And I think that, when we look at patients, they, of course, they're coming to you with blurry vision, and they think it's related to the cataract. But, when I'm identifying that the patient has ocular surface disease and cataract, before doing anything, I really like to take some time and help the patient understand that they have two disease processes. And this is important because it makes the patient take ownership of their own diseases. And so, if they do, even despite treatment, become more symptomatic after surgery, then they know it's not because something went wrong with surgery. It's not because, I had a complication. It really is because, it's part of their disease process. And it's also important for them to realize that the ocular surface disease is a chronic disease, that there is no cure, and that it's going to require some level of chronic maintenance. Whereas the cataract, once the cataract's removed, it typically resolves the issue. So let's talk a little. So treatment categories certainly include anti-inflammatory agents. Here in the U.S., we have access to cyclosporin and lifitegrast, and of course, topical steroids. Generally speaking, if the patient has corneal staining, I have a low threshold to add topical steroids. Topical steroids rapidly help to heal the surface of the eye. If I think that there's someone that's going to have chronic inflammation issues, then I will have added, lifitegrast or cyclosporin to those patients. But certainly those are long-term medications. And so if I start them preoperatively, it's because I think that the patient has moderate or greater disease. MGD treatment. So there's a number of different treatments that are out there. One of the key principles of MGD treatment is that you have to relieve the chronic obstruction. So dysfunction at the level of the gland creates thick, more viscous oils, and that clogs the gland. We have a number of different treatments that are out there. I use LipiFlow thermal pulsation commonly. It has more than 30 peer-reviewed studies that all really confirm that it's an effective treatment to increase tear breakup time and reduce symptoms of MGD. IPL is also a common treatment. However, I generally am not using IPL in my pre-cataract patients or pre-surgical patients, mostly because it is a longer course. Patients require treatment once every 3 to 4 weeks and a series of, in my clinic, typically 4 treatments, but certainly is another option for chronic MGD. So focusing on LipiFlow, the reason why I like LipiFlow is that the device looks very simple, but it's actually quite scientific. So the device goes underneath the eyelids and it vaults over the cornea. There's actually a resistor, so no heat is exposed to the cornea. And then the device actually precisely places pressure, all while it's continuously being heated to 42.5 degrees Celsius. And so that vectored pulsation drives the liquefied secretions from the meibomian glands out of the gland. to relieve the obstruction. So why do I choose LipiFlow? We talked about it has been extensively studied in the literature. It was first FDA approved in the US in 2011. So we've had it for not quite a decade, but quite a long time. It has an established safety and efficacy. We talked about how it reduces symptoms and also increases tear breakup time. But I also love that it's small, it's portable, it's easy to integrate into clinical flow and clinical practice. And patients find it to be comfortable and an efficient treatment for MGD. It's a 12-minute treatment, so patients aren't having to come back to clinic or having to stay in clinic for a long time. So let's talk about LipiFlow as it relates to the pre-surgical patient. And I thought maybe we'd start by just walking through the literature. So first, LipiFlow has been shown to improve inflammation and osmolarity levels. Our group at Duke found that there was a 50% reduction in MMP9 positivity rate, and there was a significant reduction in osmolarity levels pre and post LipiFlow. This is a study that I think is very interesting. So they took patients that divided them into two groups, and they measured their symptoms, and they looked at essentially the impact of treating ocular surface disease before surgery. So on the right side, so that's the control group, you'll see that both the thermal pulsation group and the control group had similar baseline symptom severity. But what you can see in the control group on the right is that 1 month and then out to 3 months, patients continued to have increased symptoms on average by the SPEED questionnaire. And if you look at the group on the left, so they had the thermal pulsation treatment prior to surgery. So at baseline, they're the same as the control group, but at 1 month and even out to 3 months, the patients had a reduction in their dry eye symptoms. And so, this is really an important study to me because it shows that if we treat MGD and ocular surface disease before surgery, that patients are going to feel less symptomatic. And that's, really as a clinician, the ultimate goal. We want our patients to feel the most comfortable after surgery. This is a study that was presented at ASCRS last year. And again, looking at patients in the pre-surgical arena. So they had pre-treatment with LipiFlow. And they had measurements of keratometry and topography before and after the treatment. And they found that in the group that actually had their LipiFlow treatment, that 40% of the time, there was a change from the original surgical plan. And the one that I have highlighted here that really stood out to me was that in 28% of the cases, so just over a quarter of the cases, the surgical plan changed from no intervention to adding an LRI or a toric. So that really shows me that your astigmatism measurements are very much impacted by MGD and ocular surface disease. And if we don't take time to treat it, that we're going to actually erroneously treat our astigmatism or leave astigmatism behind because we're not accurately measuring it because of the interference of ocular surface disease. So we talked a little bit about meibography earlier, but I think meibography is such a great tool, and it really is something that adds value to the clinician. When I look at meibography images, not infrequently, I'm surprised to see what I see, meaning that I look at a patient's glands and I can diagnose the MGD, but I might not think that they're a severe MGD patient. And I get meibography and I might see that they have, loss of 80% of their glands. If you look at the bottom right there, you can see an image of a patient that's lost, 80, 90% of their glands. And that image really helps me to educate the patient, to help them say, okay, this is what I look like, and this is, what I likely started. And it gives the patient ownership of their disease, and it gives them insight into their disease. It's something that they can see. I think patients all understand, okay, if I lose glandular tissue, that's not a good thing. So myography helps me as a clinician. It helps my patients understand and accept their disease. And also, it helps me to set patient expectations. So a patient who has very mild meibomian gland atrophy, I would expect them to respond very well to the lipoflow thermal pulsation treatment, or really any MGD treatment. But a patient that has severe atrophy just as the name implies, they have severe disease. And so that's a patient that I want to spend time educating that they're going to require multiple therapies, that there isn't going to be one single treatment that's going to benefit them. So they might be the patient that's on an immunomodulator topically. Maybe they're having lipoflow thermal pulsation, and maybe they're also using over-the-counter tears, and maybe all of those things don't make them 100% better. So a lot of it's about setting those expectations for patients. So how do I talk to my patients? Well, I told you about setting their expectation, but you also need to set their expectations not only in terms of their disease, but also what they should expect after the lipoflow treatment. I always tell patients it takes 2 to 4 months to see the peak effect. And that's because just the act of relieving the obstruction is part one. And then part two is their body has to start to produce better, more normal oil. And also, I think it's important for patients to understand that dry eye is a multifactorial disease. We talked about that in the TFOS JUICE-2 definition. And part of treating dry eye is treating the MGD. But that, you also have to treat the other factors, whether it's allergy, eyelid malposition, etc. Okay, so let's start kind of close things up here with a case. We have a 65-year-old woman. She's coming in for cataract evaluation. She has her classic symptoms: glare, blurry vision. She's using artificial tears, and she takes amitriptyline at night for sleep. I always ask all my patients what their goals are. And when I asked her that question, she said, I don't want to wear glasses for distance or for when I drive. So I already know at the outset, she's told me she has blurry vision when she's reading. So that's a red flag to me. When patients say that they have blurry vision with an activity that I know requires a real stable tear film, I'm already thinking about some dry eye disease. And she's on medications that can create dry eye disease. And she's also of a slightly older age group, and so she's also at risk there. Looking at her preoperative measurements, so she's got what looks like an abnormal topography. If you look at the image on the right, you can see that the Myers are irregular, and also there's this area of elevation inferiorly that doesn't really fit there. The patient also has MGD, a reduced tear breakup time. She has some corneal staining. And sometimes, on topography, corneal staining can look like elevation, depending on how heaped up the epithelium is. So just something to look out for. Also on topography, if there's missing data, that also can be present when there's dry eye disease. So her, so her MMP9 is weakly positive, and she has an abnormal osmolarity. And on our biometry, we're measuring against the rule of stigmatism. That's what her lids look like. You can see the thick, buttery secretions and the telangiectasias. And then on the right here, rapid tear breakup time. So that's the actual tear film. We want that to be stable and intact. So what are the major issues here? Well, I think it's pretty clear that she has dry eye and MGD. And what are we going to do next? Well, if we're following our algorithm, we absolutely have to press the pause button. And we need to optimize the surface and then repeat our topography and biometry. And also, critically, we have to talk to the patient. Remember, she has these expectations of not having to wear glasses at distance, and that might not be realistic given her dry eye disease. But that she also really just needs to understand that she has two disease processes going on. So the patient had lipoflow treatment, and then my standard is that typically about 4 weeks later, after they have the lipoflow, I have them come back, I check their ocular surface, And I also repeat the biometry and topography. So sure enough, her tear breakup time did improve up to pretty close to normal, 9 seconds. Her MMP9 was negative. But so important here, look at her astigmatism. So there was a change in astigmatism that changed the recommendation of my actual treatment plan. So her astigmatism reduced from 1.57 diopters to 1.14. But even more importantly, the axis changed by almost 40 degrees. And so this really shows the impact that ocular surface disease and MGD can have on our measurements and our surgical plan. And my toric IOL that was recommended initially was a T5, and after treating her MGD, went down to a T3, so critically important. So in summary here, addressing ocular surface disease and MGD prior to surgery is critical. LipiFlow effectively treats MGD and improves perioperative symptoms and improves tear film chemistry. I think those are such important things that we've learned from the literature on LipiFlow. And, on a practical level, LipiFlow is easy to integrate into clinical practice. I want to thank you guys so much for your time and allowing me to share my insights on such an important topic. Thank you.
Thank you, Dr. Gupta. That was a wonderful, wonderful presentation. We have questions that are coming in. So at this time, I will move the questions to the live view screen for you to read them. And for those of you listening, please feel free to type in your questions, and we'll spend the remainder of the time trying to get to as many as possible. So let me know, please, if you're able to see this first question.
Not yet, but here we go. Okay, so our first question, is there an amount of atrophy or gland loss that you would decide not to perform LipiFlow? I think that's such a great question. So if a patient has 80 or 90% gland atrophy, so I really think people can fall into two camps. You can either choose to do nothing, or you can try to preserve the 20% that are still there. So I fall into the camp of trying to preserve the 20% that are still there. So I will still treat patients with LipiFlow in that setting, but that is where it's so important to have that candid conversation with your patient and help them understand that if you've lost 80% of the tissue, which supplies that oil, that unfortunately, it really is an uphill battle, and that they are going to be somebody that requires polytherapy. And that LipiFlow, the treatment for their MGD, is just one piece of that puzzle. And so, I'd want to manage their expectations and make sure they weren't, having the procedure thinking that, hey, this is going to cure or reverse all of my dry eye disease. All right, David, you got my next question. Okay. After the LipiFlow, MMP9 became negative. Can LipiFlow reduce the inflammation? So I think this is an interesting question, because we don't often think about MGD and inflammation. But clearly there's some sort of inflammation that's going on at the level of the glands. There's some basic science work that has shown that neutrophils play a key role in creating MGD. And so in the study that I presented, we were actually really surprised to see that the MMP9 was reduced. And I think that, if you look to the TFOS due to that vicious cycle of inflammation, so that if you go through that cycle or circle enough times, that over time, there's decompensation, and then, repeated circles or cycles through that inflammatory cascade. And so I think that if you can actually treat the surface of the eye to help to reduce that hyperosmolar state that sort of drives that inflammation, then I absolutely do think that LipiFlow can reduce the inflammation. Our study was not a basic science study. It was actually, a clinical study in patients pre and post LipiFlow, but I think it is interesting that I do believe it can.
Okay, next one here coming up.
Great questions, you guys. Okay, so our next question, after LipiFlow, when do you expect to see clinical improvement? So in general, I think it takes 2 to 4 months to see the peak effect. Often I say that to patients because we all know that there's resolution of their actual obstruction. So, and usually, I used to see patients at around a month, and I would notice that, hey, their oil glands are flowing better, their tear breakup time is improved. But sometimes their symptoms weren't at the peak of improvement at a month. And so I just started seeing them all back at 2 months, at which point the improvement in the objective findings, so the tear breakup time, and also their reductions in symptoms kind of mirrored themselves. So in the pre-surgical patient, of course, I want them to be less symptomatic, but I also really care about their tear breakup time and some of those objective parameters. And so I see them back in a month and repeat the testing at a month, whether topography and biometry typically. For patients that are having LipiFlow, not in the pre-surgical patient, but in your classic MGD dry eye patient, I typically see them at 2 months. And I am measuring their tear breakup time before and after. And we do give them a questionnaire so we can track their symptoms. I see them at 2 months, and if they're all aligned, great. And if they're not, then I see the patient back at about 4 months. Okay, so next question, what's the difference between MGD and posterior blepharitis? Those are the same to me. Posterior blepharitis and MGD are synonymous. Anterior blepharitis would be, more like that crusty lid margin disease, staph infection maybe, whereas posterior blepharitis, the posterior lid, is what includes the meibomian gland. So they're synonymous to me. Next question. So why does OSD get worse after cataract surgery? So if you go back to the first few slides that we talked about, the crux of why OSD gets worse after cataract surgery is, in my opinion, twofold. One, we are not appropriately diagnosing MGD and ocular surface disease in these patients. So we assume that a lot of them don't have it, and then we're surprised postoperatively when they come back with symptoms. But two, there's a transient neurotrophic effect. So the act of actually making an incision in the cornea causes some disruption of the corneal nerves, which leads to destabilization of the tear film, leads to increase corneal staining, irritation. And so, and then if you put on top of that, look at what we do to patients after surgery. We make them take topical NSAIDs, which are toxic to the surface. We put them on drops that contain BAK. And, there's, so not just the act of surgery, but everything that happens in the postoperative period that's required for adequate healing also contributes to OSD. Okay, next question. Do you use azithromycin eye drops as an anti-inflammatory agent? So I don't typically use azithromycin eye drops because they are, here in the States at least, they're expensive, and for a while they weren't being made. And they're not FDA approved for treating inflammation. They're actually approved for conjunctivitis. If I do want to use something in that family, that I will actually use oral medication like doxycycline or azithromycin. But those, I don't find those to be a good perioperative treatment. Those tend to be for patients that have chronic MGD, chronic inflammatory related issues. And so, of course, there is some negative to that, which is that not everybody tolerates taking an antibiotic on a regular basis. And of course, always a concern for antibiotic resistance. So certainly an option that's out there for chronic MGD patients, but with some limitations. Okay, next question. So how severe or what metrics of dry eye will you choose to treat dry eye first and delay surgery? So if you look at the algorithm, any patient that has an abnormal screening test, so whether it's symptoms or abnormal MMP9 or osmolarity, or on clinical exam, if I see corneal staining, those are all sort of hard stops. You could say, well, okay, if my patient doesn't care about having a refractive outcome, can I choose to treat it later? You can choose to treat it later. That's always up to the clinician. But that I would want to make sure that the patient did not have refractive expectations. And I would want to make sure that the patient understood that they will be symptomatic afterwards and that they their dry eye will become likely become worse after surgery. And when we look at our thresholds, I think that certainly any sort of abnormality. Let's say I'm going to do a toric lens or a trifocal or a multifocal or EDOF lens. I really want the ocular surface to be pristine in those patients. So I have a very low tolerance for any dry eye. Whereas, for somebody that doesn't have a refractive goal, that doesn't want to delay surgery, I'm more willing to accept that there could be some dry eye and proceed and then plan to manage it afterwards. Good questions, guys. Okay, so the next question is how long between MGD treatment and surgery if we find that before surgery? So if you're following kind of what I proposed in our case there, I typically wait about 1 month, 4 weeks. And that's because that gives the patient enough time to have some production of that normal meibum. If the patient started out with some corneal staining, I might even add a short course of a topical steroid just to rapidly rehabilitate the corneal surface. So that's an option too. You just want to make sure that when they come back in for their measurements, if they had corneal staining, you want to make sure that's resolved. If they had a reduced tear breakup time, you want to try to normalize that. So it's metrics based, but after I see them back in a month, if they're still not better, well, then we go back to the drawing board and we add more things until they are better. So just because it's a month doesn't mean that, okay, we waited a month, now we're going to do surgery. Our next question is how many percent of patients before cataract surgery do you perform lipoflow treatment newly? So that's a great question. So I would say that of my patient population, probably about 25% of them are getting lipoflow preoperatively. And part of that is my patient population. I work in a tertiary care academic center. And so, a lot of my patients probably have had treatment prior to even coming in. And also, of course, the logistics of cost and things like that. I think that if we had zero cost, that all of my patients would get it. But there's, of course, a financial consideration as well. Our next question is, can a topical anti-inflammatory eye drop be given along with IPL or lipoflow? So for me, the answer is always yes. And I assume that when you say topical anti-inflammatory eye drop, you mean cyclosporin, lifitegrast. Yes, for patients that have chronic disease, I absolutely feel that there's a role for combination therapy. And part of, deciding that is deciding the severity of your patient's disease. So somebody that is mild disease may not need a topical anti-inflammatory agent in addition to these treatments, but somebody that's more moderate to severe, whether it's based on symptoms or actual objective clinical findings, those are patients where I will start that at the same time as my other treatments. Because as you know, those treatments are not rapid. They often take 2 to 3 months, sometimes even more in the case of cyclosporin, to build complete levels. Okay, our next question. Are there any tips to extend the benefits of LipiFlow treatment? So I think that, one thing I tell all my patients after LipiFlow is to have, to make time once a day to do a hot compress. And it can be in the shower, just, that clean washcloth with the heat there. But I do feel like if the patients that do a warm compress, even if it's not every day, if it's 3 to 4 times a week, I feel like that does help to extend the benefits because it encourages the flow of the oils. When you think about warm compresses at home in a patient that hasn't had thermal pulsation, those patients, the warm compress isn't very effective. But once the obstruction has been relieved, that really helps to help the patient be more successful in their efforts at home. Okay. The next question is, which one is better for MGD, LipiFlow or IPL? That's an impossible question to answer, and mostly because it depends on your patient. So the patient that has a lot of facial rosacea, I tend to start with IPL. For patients, for everyone else, I tend to start with LipiFlow just because it's just in terms of the actual logistics of it. So most of my patients don't want to come back once a month for IPL treatments. And of course, patient comfort, the IPL is more uncomfortable than the LipiFlow. So generally my staging is to offer LipiFlow pretty much in any patient unless they have moderate or plus gland atrophy, in which case I might start with IPL if they have a lot of gland atrophy, because I think the repeated expressions are helpful. It's important to note patients don't love manual expression, that it is uncomfortable for the patient. So, I think that kind of picking and choosing based on your patient's clinical factors is the best way to go.
Dr. Gupta, the questions continue to pour in. So if you have a little bit more bandwidth, we just have a few more questions and then we'll be at the top of the hour. Can we answer a few more?
Yeah, of course. Okay. Our next question is dry eye treatment procedure after refractive surgery like LASIK or SMILE. So I think if you're asking the question, should you treat them after surgery? I actually think that if you have the choice, you should treat them before. But let's say you've inherited this patient that's had refractive surgery and now has dry eye. So if you look in the literature, there was a nice study published by Steve Schallhorn, of course, who has great refractive surgery exposure through the military here in the US. They took patients that had significant disease after laser vision correction that didn't get relief from traditional therapies. And in that, what I would call severe population, they found a benefit. So I would absolutely feel comfortable doing LipiFlow in a patient that's had SMILE or LASIK, but I typically would want to wait about a month, 4 to 6 weeks afterwards. I wouldn't want there to be any sort of risk, and I think waiting until the appropriate, post-op healing has happened. Once that's done, I think there shouldn't be any hesitation. Okay, our next question here. So how about a patient with major meibomian gland atrophy? Any suggestions on how to treat dry eye before surgery? does LipiFlow still help? So we kind of addressed this a little bit before. I still think it's worth doing the LipiFlow treatment. But this is the patient that I'm going to sit down and say, you have very severe disease. If we can keep you where you're at, I'm going to be very happy. Of course, the patients don't want to hear that. They want to get better. But I also set the expectation with my patients that it's going to require a number of different treatments. So they might be the patient that's on a topical immunomodulator. They may also be getting LipiFlow. They may be doing daily compresses. They may be taking omega-3s, and we keep adding until that patient starts to feel better. Next question, good question. How often will you use meibography to diagnose MGD? So meibography, is the infrared image of the meibomian gland, and meibography will diagnose meibomian gland atrophy. So the presence of meibomian gland atrophy for most patients means that they have some level of MGD. But remember, we're not able to actually look at the function of the glands on meibography. So I still think it's important to do a clinical examination of the lids and, putting a little gentle pressure on the eyelids. But in all of my patients who come to my clinic for a dry eye evaluation, 100% of the time, I am getting meibography. I also, in my refractive surgery patients, all of my refractive surgery evaluations get meibography. And that is because we all have seen this patient that has just severe dry eye disease after refractive surgery, and we can't figure it out. And those are the patients that often will have meibomian gland atrophy. And so I think it's very useful to diagnose that prior to surgery so that you can have a good conversation with the patient, especially that young refractive patient who, really isn't thinking about dry eye disease. They're focused on getting rid of their glasses. Okay, I think we're going to get to our last couple of questions here. So, so this question is related to treating dry eye after surgery. So the patient has surgery, their dry eye was not treated before surgery. So when's a good time to treat dry eye after surgery? And do I choose a medication or the thermal pulsation? And so I think you have to start treating early. Part of the problem with postoperative dry eye is just simply that our postoperative medications create the dry eye disease. So I have if the patient's really symptomatic and uncomfortable, if they're still on an NSAID, I will take them off the NSAID, keep them on the steroid. For most patients, after a week, you don't need an antibiotic. And so, getting them on the lowest number of drops is important. Supplementing with artificial tears, I think you can do that from the beginning. Drugs like cyclosporin or lifitegrast, I usually wait until the patient's off all their postoperative medications before I decide to put them on that kind of a medication. Now, if they were on it before, I just let them continue that through. And then for treatments like thermal pulsation, I like to wait until about 6 weeks after surgery. By then, they're usually off their topical medications. We can assess them kind of in their true state. And also at that point, I would expect that the surgical incisions would be well healed. Great.
Dr. Gupta, thank you so much. Thank you for answering all those questions in almost rapid fire pace. That was wonderful. Thank you.
Thanks so much.
Thank you so much. And just a quick note to the audience. If you'd like to learn any more about the products either mentioned today or within the Johnson & Johnson portfolio for ophthalmology, you can visit any of the websites below to learn a little bit more. Dr. Gupta, please let me thank you one more time on behalf of Johnson & Johnson and the Asia Pacific region. Thank you for joining us.
Thanks so much for having me.
Thank you. We hope to see you here soon.
Yes. I'll be there.
Wonderful. Thank you. And thank you everybody for attending this evening, and have a nice day.